It's episode 1 of EndoMentor. We're back on a live, and I'm going to be joined by Dr. Farshey. Here he is. That was quick.
How are you, man?
Good, good. We're back for round 2 of episode 1.
You and I seem to keep hooking up on weekends that there's Formula One, and I have to kind of record it and not watch it live.
Yeah, I've got mine recording downstairs as well. I think we're both catching up straight after.
Yeah, I just have to find a suitable stand for the phone. I guess I'll just hold it or something. How have you been? How was the course?
Good. Course was really good. I was with Karina Patel, guys, for anyone who doesn't know, on her endo expertise course in London, which was great. And learned a lot. We did a bit of instrumentation and complication management, curved canals, sclerosed canals.
Was it a big hands-on component, or was it more didactic?
It was a lot of hands-on. So for me, that's perfect, because I feel like I've done a lot of reading, watched a lot of lectures, so I need that hands-on training to supplement all that learning I've done.
Yeah, I used to give a lot of lectures for various companies. I was a key opinion leader for Dentsply back in the day when they were really truly an endodontic company and not part of this big conglomerate. And they were really passionate about endo, and they would do they had 2 styles of courses they would do. They would do a 1 day, all day, where the morning half is didactic and the afternoon half is a little bit hands-on, like on plastic teeth, just to kind of show the armamentarium. Yeah. And then they would also have another model, which was a 2-day. 1 day was didactic and 1 day was hands-on. And the people really got the most out of it when it was a 2-day course, just because having more work with the hands-on, having more time with it, it really gave you a better grasp of some of the stuff that they're trying to introduce. I had, we just bought a laser for our practice for disinfection. And we had a 1 day, all day training. So it was that kind of a model. And it was like 6 hours of didactic and then 3 hours of hands-on. And I find myself, you know what? Like, I'm in that chair now where I'm the student, and I'd love to have a little bit more hands-on. But, I think efficiency and people's time is something that a lot of the companies are taking into account with these courses.
Yeah, there's a lot of ways to run it. This one's 3 days worth, split over 3 different weekends. Tends to be an hour of lecture, then hands-on for the rest of the morning. Then in the afternoon, it's again lecture, then hands-on, and then maybe finish off with a little small mini lecture at the end. So I think it works quite well. So it's been good. It's been really good.
Nice.
Awesome.
So we have deja vu all over again, huh?
Yeah. So what I'm going to do now is I'm going to start the screen record, and then we'll roll into the actual presentation or lecture, whatever you want to call it. Welcome, guys. This is episode 1 of EndoMentor. I'm joined today by Reza Farshey, aka Endogenie, and we are going to be talking diagnosis. I'm just going to go lift my laptop up so I can read my notes as we go through this. So, deja vu, like you said. Shall we dive straight in? So, what is diagnosis?
Diagnosis is the process where you, as a clinician, are able to gather the necessary pieces of information to arrive at the correct answer as to what the patient's problem is. And that in turn allows you to propose the best, most accurate way of managing that problem.
Yeah.
So that's really, if I were to explain diagnosis to a layman over a cup of coffee, that's how I would describe it. And then I would immediately say that diagnosis is not only, it's partly art and partly science.
Yeah.
The science you can pick up from reading a couple of chapters in a textbook. and the very thirsty, young, impressionable students in us will pick up the science with tremendous amount of accuracy within about a few months. So that's the part where there's no debate about. But what makes diagnosis accurate in one person versus not so accurate in the other is the art component. And the art comes from personal intuition, from experience, from looking at all the angles and seeing where are the possibilities where I, as a clinician, can be led astray. And I want to identify those possibilities and avoid them at all costs.
Yeah.
So that is what makes the art in the art and science of diagnosis. Yeah. And I've had my fair share of sort of these failures over the years. You, as a clinician, always learn more from your failures than you do from your successes. And this has kind of helped. I put sort of my experience, my perspective on diagnosis as best as I could in print. And that's when, with a group of collaborators I was involved in, I wrote a chapter on diagnosis in a textbook like 5 years ago entitled Current Therapy in Endodontics. Yeah. And I have some unusual ways of arriving at the right answer from a patient to help make a correct diagnosis. But that in a nutshell, Jabir, and we can kind of break it up and unravel them in different pieces, but that's really what diagnosis is.
Yeah, and you've got a very interesting, actually maybe unique way of categorizing things that you'll look at when you're diagnosing a case. So we're looking at subjective versus objective. What's the difference there, and why have you come to make this differentiation?
I think we need to be aware that not all information that's presented to us carries an equal weight or has the same implications and consequences. For example, if I were to examine you, let's say you're the patient, Jabir, yep. And I'll take and you tell me, you know what, I have pain on my lower left side. And I take a radiograph and I see a giant carious lesion on the distal of lower left 6, complete and frank into the pulp chamber, like a hot tooth. But then I ask you, you know, where is your pain? If you are a very self-aware patient and your pain is somewhat localizable, you can describe that information, and that's pretty accurate to me because it is consistent with what I see independently. Yep. But you're going to have a segment of the population that are inherently phobic and have dental anxiety, and you know, you walk into the room and they're kind of gripping both sides of the armchair, and their blood pressure rises up 10 points just from seeing you. That kind of a patient is not capable of providing you unfiltered, objective, accurate information. That information is going to be skewed very much. And I think we have to be able to differentiate that and know when to not take subjective information to the extreme, because that can lead us to misdiagnosis.
Yeah, it's the imperfect narrative kind of thing. You know, the patient isn't going to give you a perfect quality of information. You need to work it out with, okay, what are they saying versus what can I independently assess and say for sure?
Absolutely. So the best way to start diagnosis is to identify what pieces of information that I am gathering today goes into the objective column. Yeah. And what pieces of information go into the subjective column, and then having this simple formula in your mind. Diagnosis equals objective information plus subjective information. Yeah. And then depending on the type of patient that you have, you're going to weight that bits of information differently.
Yeah, yeah. if you've got a dentist in the chair and they're telling you, I've got XYZ on this tooth, and then you're going to believe them a bit better than a more lay person saying, oh, it's somewhere here, and yeah, sometimes it's this tooth, sometimes it's that tooth. Then you're a bit more, it's a little bit more confused. So you need to weight your independent assessments higher.
Yeah, you know, more so when you're examining the teeth in a quadrant and you're checking for percussion sensitivity. And if the patient is extremely dentally phobic, you're really not going to, in some cases, get a very clean and clear set of responses from them. You tap on a tooth that's not the offending tooth, and they're going to jump because they perceive it to lead to pain, and they preemptively jump. And all I'm saying is just try to recognize that and try to work with what you're given to filter that information so you don't get yourself too confused.
Perfect. Should we dive into subjective?
Yes.
And the things that you dropped in that category. So starting with, for example, the complaint that the patient comes with, the history of that complaint, and then their report of medical and dental history, stuff like that. Where are we looking here?
So subjective is any piece of information that you, with your own eyes, cannot clear independently, that you're relying on information from the patient. So that can be the chief complaint, absolutely, because you're getting a perspective from the patient about what's going on. That's the history of present illness, even their medical history and dental history. You know, I gave an example last time. A few years ago, I treated a 70-some-odd-year-old patient, came in for consultation, and in reviewing the medical history, you know, I noted that he had circled yes to HIV. And and it was sort of a necrotic pulp, and I wanted to decide if I should give him preemptive antibiotics if his immune system is compromised. So I asked him, I said, you know, what's your T cell count? Do you have that checked regularly? What's the viral load? And he said, what? I said, oh, I'm just kind of talking about, you circled yes on HIV. He goes, oh, heavens, no, I don't have HIV. I may have missed that. And it may have been another question that was just below HIV. So that just really reinforces the issue that even though it's medical history and it's an official form, it's still filled out by someone who is not an official party.
Yeah. And
you have to really take that as subjective information. So that is subjective, but really the main thrust of subjective information, which can really lead you to the right diagnosis or lead you astray, are the vitality sensibility testings that we do. And so percussion testing, palpation, examination, cold testing, these are very, very subjective. And really, they are the cornerstone of the informations that we get from the patient during our testing. Now, objective information is anything I can independently see on my own. I look at a radiograph, my interpretation of it, even though it is subjective, because my interpretation of the radiograph may not be the same as the dentist next door, but for this purpose, we are part of the objective party.
Yeah, just dropping back to subjective, when you're doing a sensibility or vitality testing, is there a certain method that you prefer, EndoFrost, EPT, etc.? What would you recommend, you know, in your experience is better?
So in my experience, and in most of the endodontic colleagues that I talk to about this, whenever we talk about, we don't ever use EPT, not typically. So I use cold testing, and I like to use but whatever refrigerant spray that you have. Ours is tetrafluoroethane, which is, I think, minus 25 degrees Celsius. So that really minimizes a false negative because it's cold. But what a cold test it allows you to do is not only to gauge whether a tooth is responding to the stimulus or not, with the inference, is the pulp vital or not vital? But if it is it healthy or is it inflamed? Because if it's inflamed and it's irreversible, then that would require endodontic treatment.
Yeah.
EPT doesn't give you that. EPT is all or none.
Yeah.
And EPT has, I want to say, a 10-12% false positive rate. So that error rate is, in my hands, significantly more than the error rate I would get out of cold. So overall, cold will give me the better way of getting that information.
Yeah, yeah, really key to work out what's going to work best in your hands. Like you say, you're quite experienced, so maybe other people who are a little bit younger maybe need to use both, try and get a fuller idea.
Yeah, if you do both, which do you trust? Let's say you put cold and it's negative, but you put EPT and you get positive. The human psyche kind of looks at EPT as the fact checker.
Right.
You know, they do the cold and it's negative, and then they put the EPT on, and if it's positive, oh, this tooth must be fine, it's positive. But which is very fascinating, because I don't know how we came to making the EPT the adjudicator. You know, it's just another test, and it's no more significant, no less significant. It's another test. So my advice in those situations to our colleagues that are generalists is, if it's difficult like that to come to a conclusion, refer that case out to your endodontist specialist that you work with, because he or she has more experience, can decipher more information out of the subtle pieces of the puzzle that they're provided, that I think the experience pays off in this case.
Yeah, sure. And then also with our subjective, we also have things like percussion testing. Do you tend to try and percuss a tooth which you're not suspecting first?
That's a great question, and people do it differently. And this is how I have found to gain maximum accurate information. We as people, when we're asked to respond to something, we do far better when we are asked to compare two things than to do it and ask for an open-ended answer. So kind of like an eye exam. I don't know if you've ever had an eye exam.
Yeah.
You know how like they put you into the filter and then they say which one is more clear, this one or this one? You're able to provide an answer to them. Now, if that optometrist had just given you one filter that was not the one you chose, and they asked you, is this accurate? You would have said yes.
Yeah.
Is this clear? You would have said yes. So we do better when we do relative comparisons. So my go-to way of doing it is I would tap on two surfaces of two different teeth at a time, and I'm going to call one A, call the other one B, and then say, Mrs. Smith, which one was more sensitive to tapping, A or B? Yeah. Mrs. Smith is much more capable of giving me an accurate answer that way than if I were to tap on B and say, does it hurt?
Right, yeah. Because they'll just say yes.
Exactly. Or no, right.
Yeah. Yeah, that's really useful. And you've also maybe added in fracture checking into a subjective category as well.
The fracture check?
Yeah, you know, bite down on the cusp and then.
Absolutely. Well, it is subjective, but Jabir, just because something is subjective, it doesn't mean it's worthless.
No, no.
It just means like, hey, high alert, look at that information. Does it jive with the patient profile? Again, if you're dealing with a very, very anxious patient who has an incredibly low pain threshold, when you bite on a bite stick, it may not be cracked and it may still feel tender. So you may need to do it on a contralateral tooth and just ask them, is there a difference? And they may be able to help you gain more accurate information that way.
Yeah, yeah. Just, yeah, like you said, all of these bits of subjective information, it's up to the clinician to weight it according to the patient in the chair. So
Yeah,
not that any of these are not important, or and not any of these are useless or anything like that. But it's down to your clinical judgment to weight them.
exactly.
Shall we move on to the objective side? The things that we are going to do, independent of the patient sat in the chair. What are we looking at? Start from extraoral. What's the first things we should be, just having a little check on?
Well, the first thing before you even kind of do anything, which I think, thankfully, we as a profession are doing that across the board now more because of COVID-19, is to get their temperature. Because a febrile state, if they have a temperature above normal and there is a dental infection, that is an implication that systemically the dental infection or the abscess is affecting them. And that is smack in the middle of the reasons why we should prescribe antibiotics. So I think getting their temperature is one. And then you want to look at the patient extraorally. You want to look for any asymmetries, because if they have a subtle abscess or a cellulitis, you're going to see an asymmetry one side or the other. And that is valuable information. Lymph nodes, relevant lymph nodes, submandibular lymph nodes are very, very commonly exactly in dental cases. So that's the bit of our extraoral. And then intraoral, you can find whatever flow that you like as long as you tick off all of the tests that you got to do. Some people like to examine first, look at the quality of the restoration, look to see if there's any decays, look for any cracks, and proceed with periodontal probing, and then examining the tissues. As far as palpation goes, you want to just take an index finger and run it along the mucosa of the entire arch and see if there's any fluctuance, softness, or any tenderness by the patient. Examine for any sinus tracts that are evident. These are signs that a nerve is infected and is straining itself out. And then once you've done that, then you can go into your tooth testing. And really what I do is limit my tooth testing in the majority of cases to just 2 tests. And there's a reason behind it. Look, if I had someone that wouldn't judge me in the chair, I can have 18 different tests and they will lead me more accurate information possibly. But each of those tests is causing harm, anxiety, and discomfort to the patient. This is our first opportunity of exposure to the patient. We want to take that information that we're going to get by harming the patient and really be efficient with it. So I'm not interested in torturing the patient. So I've decided that I'm going to limit it to 2 things. One is a percussion test. The other one is a cold test. Both of these together, hopefully when they are in harmony, along with my information, make me feel very confident in my ultimate diagnosis. So percussion, we kind of touched on this a little bit. I don't ever like to tap on the offending tooth and ask the patient, does it hurt? Because hurt has a very broad range of implication. Does it hurt a little bit? It hurts moderate, it hurts a lot. The patient doesn't know. What are you trying to ask really? So they may inadvertently say yes to something that was really supposed to be no. So instead, I like to percuss 2 different surfaces of 2 teeth in random order, ask them which one, if any, is more sensitive. Most of the times they do a good job of saying neither. Most of the times they do a good job of saying both, to which case I say, is one demonstrably more than the other? And then take it from there. And if you have, let's say you do tooth 1, tooth 2, the patient says slightly tooth 2. Then I'll go to tooth 3 and tooth 4. The patient says neither. Then I'll go to tooth 4 and tooth 2. If the patient says tooth 2 slightly, that's an accurate answer because I've just randomized it. The patient has no idea that I'm tapping on the offending tooth, so they're not biasing their responses. And so you're able to get very accurate information using a very inaccurate source, i.e. the patient.
Yeah. So yeah, it makes sense. You know, it's that double blindness or single blinding, because you know which one you tap.
Yeah.
So that's really important. We'll leave radiographs just to the end because we'll obviously move on from there. You also talk about pain scale as well. Where does that come in?
Yeah. So with the cold test, it comes in. The two most difficult types of patients to get an accurate read from a cold test are the really, really anxious patients that have a low threshold for pain. The ones where you just blow a little bit of air on the side of the tooth and they jump out of the chair. That's very difficult to get accurate information from, and I'll explain why. The other kind of patient that is very difficult to get accurate information from is the type of patient that hates local anesthesia and is completely zen in the chair, willing to have restorative work done with no anesthesia.
Wow.
They have a very high threshold for pain. So you're not likely to induce a sensitivity from a cold test in those patients. But assuming your patient is neither one of these extremes, when you have to do a cold test, it's important to adhere to a couple of things. First, you want to find out, why are you doing a cold test? First and foremost, is the pulp of the tooth dead or alive?
Yeah.
And then if it's alive, is it irreversibly inflamed, or is it normal like the other ones? So I like to, once I've narrowed it down on my percussion test to the tooth, and that tooth seems to be the area or the tooth the patient is referring to, then I'd like to just go right to cold test with that. So I spray a size 2 cotton pellet with the tetrafluoroethane, and you want to put it in the cervical third on the buccal aspect of the tooth. That is going to partly hit the gingiva, but it's really going to be in the area where the distance to the pulp is the shortest. So you're going to get very accurate information that way.
And with the response, you're either going to get, you know, a positive, I can feel that, and a little bit of a jump. You'll either get nothing. What do you do in those in-between cases where they can feel it, but it lingers, and they can feel it, but it doesn't linger? Is there any distinction that you make between those?
Yeah. So before I do the cold test, I tell the patient, you know, a visual analog scale has always been a very accurate way to project sensations to someone else. And I like to use a 1 to 10 scale. Be like, on a scale of 1 to 10, when 1 is nothing and 10 is really the worst thing, I'm going to put this cold on the tooth if or when it reaches at least a 6 or a 7 razor hand. So that, for the most part, does the job. How quickly they raise their hand tells me about whether the nerve is functioning at a normal capacity. And then when I remove it, we ask them, you know, does it linger? Now, textbooks over the years have tried to provide a uniform standard of 10 seconds, 15 seconds, 30 seconds, minimum lingering for it to be inflamed pulp. I say there's a broad range. People are different. Sometimes, you know, you ask them, is it still hurting? No, it's actually, it's okay. It's getting better. You can either leave it at that or probe further. Oh, getting better. So does it mean it's not entirely normal? Close to it. I have something here, but it's okay. It's not painful. Okay, so you have an awareness. Yeah. Let me ask it to you this way. Does the left side of your face feel identical to the right side of your face? No, there's something there. There you go. That could be linger. It is just not at a painful threshold. And it is just a patient's lack of communicating in a forthright manner with you that required you to take that information and try to put it through the blender and get the maximum results you can from it. Now, I will say this, be very careful, because you could, in the absence of other supporting pieces of information, just relying on that can lead you astray. Yeah. So if that is your hypothesis, that that particular patient has a very low-level lingering pain to cold, aka irreversible pulpitis, you would want to do yourself a favor and use the contralateral side, run the same test, and ask them if they feel different.
Yeah, yeah.
The onset, how quickly they jump, you can tell yourself as a clinician if they were similar, how long it lasted, and whether there's an after effect. If there isn't any after effect, then that little bit of linger, even though it was an awareness, qualifies for irreversible pulpitis.
Yeah, really key information. Very subtle, but you can get your diagnosis well, not just from that, but with everything else the patient tells you as well. Always best to have a group of indicators leading you one way or another.
Exactly.
The next thing I think we should talk about is maybe the tissue quality. So obviously you've looked around, you've done your little palpation, buccally, maybe also palatally as well, because I have seen some large swellings palatally, which is quite interesting. But you know, just have that good, thorough examination around there. When you're doing a periodontal probing, looking for a suspected, you know, crack or fracture, how do you go about that exam? It's not the same as a BPE. It's going to be much more thorough, isn't it?
It's much more thorough, but there are so many other tools available to us now that helps us diagnose cracks, namely CBCT. CBCT kind of started out as, oh, you know, hands off, leave it until you absolutely have to, and you cannot get the information, you know, any other way, to now becoming the norm. At least in the endodontist world, it's the norm. Yeah. It's the unofficial norm, I should say this, not official, unofficial norm. So preoperatively, we scan every patient, including anterior teeth, because we want to make sure we are not dealing with something that is catching us by surprise later. And I think that bit of information that we get from the patient is far more beneficial than the risk of 20 microsieverts of exposed radiation to insignificant tissues in the upper anterior region. So we look at it that way. But periodontal probing, to answer your question, is just is just another tool to have a holistic impression of the patient's dental health around that tooth. If there are periodontal concerns, that needs to be addressed in tandem or in sequence with any kind of endodontic treatment. That's the reason why I would do periodontal probing. Particularly with teeth that have had root canals, you want to be very careful for deep pocketing on the buccal or lingual, on the buccal or palatal, because that is the route that vertical root fractures typically create their destruction, is on the buccal and the lingual. Conversely, teeth that have not had treatment have cracks induced on the distal or the mesial marginal ridge far more than the facial or the lingual sides. Yeah. So if a tooth has not had endodontic treatment, pay particular attention to your probing interproximally. Yeah. If the tooth has had endodontic treatment, pay particular attention to the facial or the lingual. And if you have CBCT, you can kind of ignore it all, because that gives you a lot more accurate information. Yeah, yeah. It's another really good indicator. Obviously, less available in some places. So, guys, please do use what is available to you. Obviously, we're not saying go out and buy one straight away. No, no. It would be lovely if we could all do that.
I need to know, I can see your question about atypical facial pain. We will get onto that in a further episode, so stay tuned for that. Make sure you've subscribed and all those little bits and pieces, either on YouTube or on Instagram. Should we move on to radiology? Because I guess that's a whole huge topic. We are going to be talking to Judy Endo soon about that, but very briefly, with regard to diagnosis, what PAs are you taking initially? Are you taking bite wings as well? And you know, how many are you taking? What's your method?
A PA is a must.
Yeah.
We're going to leave CBCT out for now.
Yeah.
But a PA is a must. Back in the day, we used to take a couple of different PAs from different angles to have an impression three-dimensionally with how a root curves or number of roots, canals, et cetera, et cetera. But I think one good PA is enough to get you a lot of the diagnostic information that you're seeking. A bite wing is a huge bonus, especially when you're embarking on treatment, because the most stressful part of the endodontic procedure, the part that to this day I still spend quite a bit of time on in my workflow, is the access. And having a bite wing allows you to see, do you have a deep chamber where you can just kind of drop in and you know when you're there? Do you have a shallow one? Do you have receded chamber? Do you have pulp calcifications? Do you have caries you got to manage? This all becomes so clear with just a simple bite wing. So if you want to treat yourself as a clinician, consider a bite wing, because you just get bonus information that you do not get anywhere else by adding that to your periapical radiograph. But for our purposes, we're going to look at the periapical radiograph, and I have proposed a way to systematically look at radiographs the same way. This ensures we don't miss anything, and this ensures that every radiograph that we see receives the same level of diligence from one patient to the other. And the systematic way is as follows, Jabir. Start broad, then focus on narrow. You do not want to take a radiograph up and then immediately look for any periapical radiolucencies. Even though if one is very obvious, great, that workflow is speeded up. But a lot of them are not going to be that obvious. I know this because I'm making a artificial intelligence software that can identify abnormal periapical radiographs. And those signs are so subtle, even our experts that grade these, the instructors in our dental schools, they don't not only agree with other colleagues on the same radiograph, they don't agree with themselves when they look at the same radiograph 3 weeks later. So there's so much variability, and these signs are so subtle that you're not going to gain the information, Jabir, when you take a radiograph and immediately try to look for something periapically. So instead, start broad. And by broad, I mean, look at the crests of the bone. Is it horizontal? Is it, does it have any changes in radiolucencies, suggesting that there may be a defect of the crest of the bone? So that's first and foremost. Second big thing to look at, any deep restorations or caries that are close to the pulp, because that will be an implication that the pulp has been damaged as a result. Then you look at the lamina dura that goes around the roots of the tooth. The lamina dura is that thin gray line that immediately hovers over the periodontal ligament space radiographically. And your eye at that point should trace the lamina dura in a continuous manner from the crest of one root all the way down up into the furcation, all the way down into the other root, and all the way up into the side of that. It has
Yeah.
to be thoroughly continuous for it to be normal. When it is not normal, the presentation of the lamina dura, it's either obliterated, in which case it's like a window, it's like a break. It comes down,
Mm-hmm.
it stops, and then it picks back up again. That means you have a periapical radiolucency, which may or may not be obvious, but that is what you see. Or it may be something in between, what we call a diffuse lamina dura. It's crystal clear gray, and then you see something of a gray, and then it becomes crystal gray again, crystal clear. That is a positive finding. And that is the minutia that you're going to look at with regards to starting broad, getting focused. That's the minutia with the focused part of a radiographic analysis.
Yeah, really, really key there. So the first thing, again, just to recap, crestal bone levels. Is it horizontal? Is there a drop on one side? Maybe the quality of the bone as well. You're looking for caries, deep restorations. You know, what's the quality of those look like? After that, we're looking at lamina dura, trace it all the way around the tooth. Maybe a little bit more difficult in an upper molar with the palatal root getting in the way sometimes, but should be able to do that. And like you say, intact, obliterated, diffuse. There are a couple of apps that we know about that might help people with diagnosis and case selections with regards to radiographs. Obviously, we have Endogenie AI, which is not yet ready for public release, but we're looking forward to it very, very much.
Yeah. It's, I set out on this about 3 years ago, and I thought, you know what? This is a wonderful thing. I can use kind of my spare time and come up with something that's going to help dentists. My passion has been diagnosis. I mean, I've been lecturing on diagnosis for really the past 10 years. And I came up with a very clever flow chart roughly about 11 years ago. And that flow chart was the big hit of every lecture I gave. People wanted a copy of that because it allowed their brains to process information in a linear manner and not get confused. And then, with iPhones and the apps and whatnot, I looked at that flow chart like in 2013, and I said to myself, this can easily be a computer algorithm. It's a series of yes/no questions, and it gets you into that answer. But it still required the clinician to answer yes and no. And that clinician can either be accurate or inaccurate. So I kind of put that aside. And then when AI came about, I said, you know what? Artificial intelligence can do a lot of the work for you. And I said to myself, I'll put a lot of my spare time on this, and it'll be a help to everybody.
Yeah.
Little did I realize that it is so highly regulated in Europe by CE mark, in the US by FDA. It is a piece of potentially dangerous equipment they look at. They don't look at it as, oh, it's just a tool. So they scrutinize every bit of it, and that's what's taken quite a bit of time and refining the algorithm. But we're hoping that as soon as we can clear a hurdle, I want to get this into the hands of dentists to kind of try and use.
Yeah, and if anyone wants to know more about that, we did a podcast a while back. You can check that out on the YouTube channel for a more in-depth chat around what's going on with Endogenie AI. The other thing that I've been using really, really successfully recently is Endo Prep app from it's Specialist Endo in Crow's Nest, Sydney. So MRXM, he's done some really good work. It tells you the estimated curvature, the estimated angulation of the tooth, and estimated length as well. So really, really useful in case selection. What can I do? What can a specialist do? And everything in between. So that's another one, guys, you can have a little look at if you want to have
brilliant
to help you.
Really, it's a brilliant app. I think it's exactly what should be in the hands of every general dentist.
Yeah,
because you want to have a unbiased perspective on whether this particular case is within your capability or not. And it's a great tool. So hats off to those guys.
Yeah, you can also show the patient, go, look, over 30% is really, really big. This is 65. I think, oh yeah, that's a big move, Yeah. And then they can understand that actually you either are someone who can do that kind of case or can't do that kind of case. It can give them an idea of what's easy, what's not easy. So really, really useful for a generalist or even a specialist, I think, just to kind of get the patient aware of how easy or difficult something is. So yeah, really good app. Shall we move on to diagnosis? Pulpal, periodicular, just in around 10 minutes, because we don't want to get kicked off again. I have got this recorded, but let's not have the same issue.
I'm going to make diagnosis really, terminology really simple. I think the American Association, there's different ways that you can diagnose pulps, different terminologies. The American Association of Endodontists, roughly 13, 14 years ago, they revised it. And the purpose of them revising it was to come up with terms that describe the clinical presentation of a tooth, as opposed to histological or as opposed to an abstract set of terms, clinically relevant terms. So every tooth that we diagnose gets two pieces of diagnostic terminology attached to it. One is a pulp status. The other one is a periradicular status.
Yeah.
The pulp status, it's either normal, reversible pulpitis, irreversible pulpitis. Now, irreversible pulpitis can be symptomatic. You're coming to me with a toothache, and I have to diagnose the tooth. That's symptomatic. Or it could be asymptomatic. Patient has no pain. They may have had pain in the past, but the pulp is still vital. Deep caries into the pulp is an example.
Yeah, yeah.
And then you have pulp necrosis, which is when the pulp doesn't respond to sensibility testing. And then the two other categories are the ones that have had at least some endodontic intervention. So previously treated, if it's had a prior root canal, or previously initiated treatment. Let's say they had a pulpotomy done to get them out of pain, and they come to you. So that's the set of symptoms that can get ascribed by terminology in the pulp diagnosis.
Yeah, I found that when we do this, it calms my mind in a way, because I'm going, okay, well, now I know what's going on higher up, and obviously we'll talk about periapical as well. It just gives a bit of, I don't know, a bit more confidence in what I'm doing, actually, once I've thought about it like this, as opposed to, you know, trying to pluck it out of air before I kind of saw this classification.
Yes. Yeah, it again, it's meant to convey important clinical information. If you go through the workup of a patient and you assign a correct diagnosis, I can actually literally just read the diagnosis and come up to par with the information that's been relayed and know exactly where to start. So it's got a tremendous amount of information in just those few clinical terms.
Yeah, yeah. So when we're going to the apical, then, do you want to knock those out?
So periapical, normal, and be careful what you call normal, because remember, normal means lamina dura all the way around, 360 around the roots of the tooth in question. So that's normal. Now, we said these are clinically based terminology. So the next one is symptomatic apical periodontitis.
Yep.
That is if the patient is symptomatic. If I tap with the back of a mirror on the tooth and there's sensitivity and or pain, whatever the radiograph looks like, it doesn't matter. That tooth is going to be symptomatic apical periodontitis.
Yeah.
Then the other term is asymptomatic apical periodontitis. So that is cases where the patient has no periradicular symptoms. When I tap with a mirror, percussion test it, there's no symptoms, yet my eye, going through my systemic way of looking at the radiograph, has judged an area of the root to be abnormal.
Yeah.
Periapical radiolucency, diffuse lamina dura, obliterated lamina dura, these all qualify as positive findings.
Yeah.
So that's basically how we assign asymptomatic. And lastly is condensing osteitis. Condensing osteitis is a condition where the pulp of the tooth is very minimally irritated, and it can oscillate between vital and non-vital findings from patient to patient, but instead of seeing a radiolucency periapically, you see a radiopacity. And that is also a condition that is unique enough that warrants its own terminology. So that's it.
Do you not talk about acute apical abscess or chronic apical abscess?
So they are clinical. There are clinical findings. And if someone is swollen, whether they have a lesion radiographically or not, it doesn't matter. That is acute apical abscess. So that will become the perioradicular diagnosis. If someone has a sinus tract, minimal pain, some discharge, but not intense pain, and potentially there's a lesion there, then that periodicularly becomes a chronic apical abscess. That's the distinction between the two.
Yeah, so pretty simple, really. Guys, if you haven't seen that already, just Google A8E classification of diagnosis. Just often stick it on the wall in your surgery. It just makes things so much easier. Do the same with the perio one as well if you're struggling with perio too, but we're not talking about that today. Reza, this has been amazing. What we'll do now is we'll end this live. We'll jump back on and we will answer some questions if anyone has them.
So I X out of this one and then I take your invitation to the next one?
Yeah, because I want to save this one, make sure we don't lose it so it can get uploaded onto YouTube. By the way, guys, if you have enjoyed this, you want to watch it back, it'll be up on YouTube within the next 24 hours. So make sure to head over to the link in the bio, subscribe, make sure you're following Reza as well, and make sure to join us for the rest of this series, which is going to be pretty impactful. Loads of speakers for you guys.
See you. Cheers.